there. And this type of work we are seeing now. This, you see, this boy has come with recurrent attacks of cold. We used to see more often in the winter. They used to tell, whereas summer I'm all right, only winter is a problem. And mother will say that don't play, don't that type of activity, don't be active, dull, all these things. People wish to curse him. Normally, we give a medication which causes drowsy to the child. At that time, we see only the first generation and child has antihistaminics. Child has got also dry skin. People won't take it important. And another thing is that asthma, and there is a family history will be there. Nobody is to take at the time. And somebody is writing on my screen. From this history, what do we understand? This is a progressive disease. This medicine causing a lot of drowsiness.
Durgesh Kannam sir, please stop annotating, sir. It's from your laptop. Please erase that lines. Durgesh Kannam sir.
Pawan, you can do it at your end as well as a host. You just go to annotations and the settings and you can do it.
So he was started on second generation antibiotics. He was doing very well. Then what we know that he has come back with a nasal block, and at that time not available intranasal steroids. When intranasal steroids has come, we added, child feels better, and suddenly after a few years he's come back with the wheezing nebulization. So it was a classical picture from upper airway to lower airway progression. We are noted down all these things, and there is definitely allergic etiology for the asthma was discussed. These are the things what we took photographs at that time. Even now, 99% of people are using these photographs in their talks. Even I had one of the meeting I attended, adult also they are showing these pictures. So allergic line will be there, allergic shiners, allergic line, allergic shiners, mouth grab, the mouth opening the mouth, and Dennis Morgan folds, allergy salute, alternative salute. These are all we determined at the time, and people are afraid of using the speculum, nasal speculum. That's why we told them to use this type when you want to examine the nose, because it is useful to see the mucus, and also hypertrophied inferior terminates, and also there will be definitely cobblestone pharynx will be there in the children because of postnasal drip. We are demonstrated to the people, and allergic mannerisms because like that they are doing because of nasal block. These people, along with that, there is allergic conjunctivitis. A lot of people thought different. We presented my work in 1997 or 98 to Institute of Child Health in the all the auditorium. People didn't believe it at all, and we have shown all and all that ear fingering is there, allergic rhinitis signs, involvement of the eustachian tube, all these things we have shown, tonsil enlargement, adenoid enlargement leading to long face syndrome, all these things we discussed at the time. Then we are told that thing by certain sounds by the child who was coming to you, child or adult, whoever maybe, they do these things so that it will give you clear picture that child has got allergy. Like the clearing of the throat, sniffling, itchy of the thing. Allergic click will be there. Oh, what are you doing? Suddenly people change their voice, wheezing. Like that, they used to come to you. So this gives you good idea, and we start off thinking there may be allergic rhinitis very high in India. At that time, a lot of foreigners used to come to us, and they used to tell that there is no allergic rhinitis in India. Asthma is not allergic. It is only virus induced or some other thing. Maybe then what we thought, we want to start a allergy immunology chapter of PATS. So because a lot of cases we are seeing in India, that's why we thought, and same place in Hyderabad, we inaugurated this IAP Allergy Immunology chapter. Later it is registered as a Pediatric Allergy Association of India. And we got income tax exemptions, complete exemptions we got. And what we did, that thing we want to educate public about the public and doctors about the allergy and asthma at present that time. We thought of that, and we started allergy asthma awareness program from Child Trust Hospital, going to all places of the country and going to educate the people, all the public and to the doctors. Then during Sukumaran time, as a president of IAP, we started a module called Allergy Rhinitis Comorbidity module. That ARCTM module is started, and this is the idea of me and Dr. Paramesh and Sukumaran. We have made it. Mainly my work was there totally, and we have taken a lot of people here this thing, and Dr. Paramesh and Dr. Sukumaran definitely helped us along with the other people, and we have gone to the public. We know that how to use it, how to use the first generation not to be used, second generation to be used, and intranasal steroids, how we use it. What happens to the first generation when you use it? It causes decreased, delayed REM sleep and drowsy all the time. Not because of medicine, because of your delayed REM sleep is the main cause, and cognitive impairment will be there. A lot of problems will come. We thought of that thing. And then what happened that we told them at the time we prepared that thing, there is definitely 80% of the 80 to 90% of the asthmatics have got allergic rhinitis. If you don't treat allergic rhinitis, asthma will be severe. More exacerbations started coming. When our education fruitful to us, nowadays we are not seeing much cases of asthma exacerbation into the thing, and not much admissions to the pediatric wards nowadays, mainly because of treating the allergic rhinitis along with the asthma. That is the only thing. Then what we thought, we need not to only thinking to the only allergic rhinitis. Why can't we have a united airway concept? Then we approached our cards company, and of course ARCT module is IAP module of MSD, and this is the module, WCAD module is a module of IAP allergy immunology chapter, and this is allergic airway disease education, that is called ADEX module. We made it, and again same members only almost, but this time we have taken international reviewers also, and we published, and we told that asthma, allergic rhinitis, when they may not come to you, may be coming with other comorbidities. For whenever you see a comorbidities, better to look for these allergic rhinitis, asthma. You may pick up and you treat it. The comorbidity will be better off. That's why we thought, and it has fruitful to all of us. And we did a lot of programs, and it is already published in Indian journal, Indian Pediatric Journal. A lot of people are aware of this ADEX module. Then a lot of progression has come in allergic rhinitis and asthma, and Sanofi asked me to start a childhood allergic rhinitis expertise module. This is called as a care module, and we started with the core members of 3 of us, and with that we told that definitely steroid load is more important. Though we are given algorithm and all, and also VAS score, visual analog score for that thing, uncontrolled allergic rhinitis, all the things discussed at that time. Main point of this thing is that we are seeing so many patients, same patient has got several allergic diseases. So they use so many steroids. So steroid load will be very high, and steroid load to be reduced. This one, what we mainly focus on this aspect. Then we suggested investigation for allergy IgM. Of course, allergy skin prick test was very old one. It is not very new one. What we thought, it is as good as 100-year-old one. Allergy testing, intradermal test, and followed by skin prick test. Now a lot of changes have happened in skin prick test. Take the good history and do the skin prick test. Again, you call the history, recall the history, and analyze it. What are the allergies and all? We started doing allergy skin test workshops along with that, and people started learning allergy skin tests and started practicing allergy skin tests all over India in pediatrics. Whereas along with that, there is a serum specific IgE also started recently only, of course, maybe around 10 to 15 years thing. And when this thing is available, those practitioners who are not aware how to do the skin prick test, they are recommending the serum specific IgE, like dust mite or pollen or cockroach or food, whatever may be, what we can do in skin prick test can be able to do it. And this is very useful. We told that don't do it as a panel. Whatever in the history found, then only you do it. Analyze it with the history again and come to the conclusion. Then recently we have with us, our center is the only center in Asia or Southeast Asia has got this component resolved diagnosis. Now it is called as in vitro molecular based diagnosis. We have started doing this thing because if you do the allergens, if you positive will be there, allergen maybe because it may be as a cross reactive, or when you do so many patients coming to us, I am allergic to 40 foods or 30 or aero allergens like that. Then we thought that it's not the thing, it is a cross reactive or it may be false positive reactions. That thing we thought we can able to do the component resolved diagnosis. So identify the components which are responsible for allergy. I will tell you one thing is called the peanut allergy, which is not at all common in India, but is abroad is common. If you say the peanut in USA or Europe, people will shiver. That is one thing what is happening. There, ARA2 component positive indicate that you will get 100% anaphylaxis. So you have to prescribe adrenaline, that is EpiPen, to be there involved. Like that, in India, commonest is cow's milk protein allergy, where if casein is there, definitely is a permanent one and long-lasting one. Then we show that it has to be followed up long time, and you have to maintain the casein levels. If it is falling down, child will improve. That's what we thought. Then comes to the ISAC study. We started. I was one of the multi-central trial investigator for ISAC in 2000. I think it is on 2008 or 2009. I think I sent 5 cases to that, all anaphylaxis. Excellently, we got a good results. That thing we are able to find out the cases also. But this is nothing but 30 microliters of blood will be injected into the one of chip. What is this? Is a chip. What is the chip? Biochip is there. You put it in the chip. What happens that you can get a result immediately. So this is a patient is allergic to bitch pollen B1. That means is highly sensitive for that. That's why I'm going to come to again for that. But at that time in India, it was only non-standardized allergens available. So we started using non-standardized allergens for testing, but we did find much good results with that thing. Patients will be very upset with us, and even immunotherapy was not successful. A lot of people are very telling that these are the immunotherapy is very bad, allergy testing very bad because of non-standardized allergens. We'll get false positive results, false negative results, and especially dust mite is very inconclusive results used to get. And also a lot of studies has proved recently that seems Velo study and another study published in European Academy of Allergy and Clinical Immunology that Indian dust might have less potent Indian manufactured dust mite is less potent and all it has come. Then shifted to standardized allergens, which was available in India at that time. There is a Lancet also, which is to be available. Previously, we used to use only blood Lancet. A lot of false positive results used to come. A lot of contamination used to be there. A lot of fungal allergens used to positive. When standard allergens comes, then we know that what is the things is there in India, and we started collecting the data, and we are teaching to the public and teaching to the doctors, all pediatricians, adult physicians, and ENT and pulmonologists. We started telling that there is definitely you have to use standardized allergens, which is available with standardized allergic Lancet to be used. All these things. And also we told that what are the items required for the skin prick test and all we got. And this is the in vitro test what we are doing, that in vitro molecular diagnosis, component resolved diagnosis. You see here that BOS4 is lactalbumin, the beta globulin, both are more than 100, casein is negative in this type of patient. Then of course it is DRP2, that dust mite DRP2 is highly positive. We told them that wait, you will be all right, boil the milk very highly and you can take, child is able to do it. Otherwise, patient was very afraid of that thing and patient is not. This may be improved after some time. And we started using other and slowly. That is food allergy.
అయ్యో ఇవంతా ఎందుకే
We are doing one thing is for skin prick test.
ఇవన్నీ
Skin prick test by pricking the prick with the patients used to come with that. I am allergic to banana. I am allergic to orange. I am allergic to this thing, that thing, and all. They used to come us, and we told that patient, you are not allergic to banana, and we prick the banana and prick it here. No reaction will be there. We'll tell them, and we told to the people, banana contains diamino oxidase enzyme, which blocks the histamine, so that histamine levels will be accumulated, and that's why we developed disease. So we thought of what are the foods which have got diamino oxidase enzyme, what are the foods has got highest histamine levels, what are the foods we don't histamine releasing foods also there, and some of the drugs also exacerbate the histamine release. We thought all over the country. Then we started using the intradermal test. Previously people used to use only for the drug allergies and for the venom allergies only started, and we started doing the food challenges thing with the milk, especially, which was very high in our country, and we do the milk challenges. How much challenge we were able to talk. Most of the patients may not tolerate even 1.5 ml or 2 ml also in my practice we see. And now we are not doing challenges mainly because of availability of the serum specific IgE is available for us. That's why we are not doing it all, so that it's coming down means his child is improving. But we do at present for the oral immunotherapy or sublingual immunotherapy for the food allergies. At that time we do the thing. And what we found is that food dependent exercise induced anaphylaxis, we got it cases. In that case, how to prove that thing, we started doing the exercise challenge test before and after food with graded manner, and we are able to diagnose a lot of cases of food dependent exercise induced anaphylaxis. And we have started getting children with so many cases of contact dermatitis. This patient has come from actually Sri Lanka, where patient is benzyl alkoxylene chloride, severe contact dermatitis of the both hands. So we are able to find out this special service started working, and patients able to do good service to them. Then we started using FeNO for the differentiation between the neutrophilic type and eosinophilic type, started doing, and oscillometry for our center, so that we can able to pick up early stages of small airway disease in allergic disease. We started taking the drug allergies, because a lot of people in India, drug allergies means they take the drug and dilute it and give intradermally. That is wrong. Actually, we thought doing it properly, and there is called as major determinant and minor determinant for beta-lactamase allergies, and most of the allergies in drug are not due to Ig mediated. That also we thought of working out by doing the drug provocation test in children. This patient is from Andamans. We did it, and he has got a NSAID allergy. How much? That means around 5 to 6 milligrams only he tolerates per kg. Other afterwards we are not able to tolerate. We are able to give the people how much of it. We started getting patients now for the adults before surgery, what antibiotic to be given, and if a patient has got any cancer drugs we want to give before that, please tell us whether this drug is suitable or not. Like that, so many cases are coming. Radio dyes also we started doing a lot of work on that. Basophil activation test has become very popular in abroad, but in India it is not able to come. Still we are not able to use it, because the problem is that in India a lot of people not able to do it, because once you take the blood, immediately you might inject into the flow cytometry machine. If you don't inject in the flow cytometry, we'll get wrong results. That's why this is a far distance for us at present in India. We started looking for the house dust mite when started using the standard allergens. Most of the patients coming with house dust mite allergies. What is happening? Why is happening? Then we gone to the literature and found that in Asia, 80% of the patients, 60 to 80%, more than 80% of patients are from South or from dust mite allergies. And this is the paper has come from Asia Pacific Journal, and they mapped it. And then we did ourselves HDM sensitization in children, and this is published. We are already sent for publication. Now, what is all 6 dust mite we have found out. You see that we found very good, interesting results. Here, the East India, more of a Blumia tropicalis, East zone, both. Whereas South India, more of a storage mites are more common. Whereas North India and West India, more of a DP and DP we have found out. That is the one thing what we found. I think the day will come, we have to use all 4, and that's why we are not getting good results. That may be the reason why. We published a paper before itself in 2019 with both adult and pediatric. We found in adult and pediatric together, Blumia tropical is very high in India compared to things, and we are more of them are polysensitized. So many patients are there in our in India. We are the only people who have done long survey, all over India survey. We are the people, we did a lot of work on that. And you can see here how many centers we did is a very important thing. And we presented a paper of food allergies and air allergen together in European Academy of Allergy and Clinical Immunology, and also cow's milk protein, 130 patients. Now we are published, we are sent for publication 256 patients of cow's milk protein allergy, which is very, very high in India at present. Then we thought this is the best way to approach a IG immediate allergies. Then we thought is asking for history, very important, spend at least 30 minutes for history and do SPT or specific IG, whichever you are comfortable. I am not telling you to do only SPT, and then do molecular allergology if you are available. If you're not available, don't forget about that. BAT is not available in India if you challenge. I think most of the time for general practice, they can able to pick up most of the cases with specific IG itself with history. So I just want to tell about what is our experience, how we picked up all the cases of the allergies. Tell that skin allergies, we started seeing cases of dry skin initially, and we are not much worried. Nowadays, we are getting severe florid atopic dermatitis. I got plenty of cases. I have a medical student. She is from I don't want to mention the name actually, from house surgeon. She came with severe florid atopic. So it was married. Just recently, one of the patients of 11-year-old mother has phoned to me from Bombay, severe florid atopic dermatitis. So we are getting more and more severe cases of that thing, not like what it was. To how to approach, how to rationalize. We are giving education not only patients but also doctors how to use. And we found out that 60% of the patients' atopic dermatitis is exacerbation due to dust mite, and 30 to 40% due to food allergies, mainly milk allergy. Without testing, don't stop milk. Milk maybe, or milk allergy means, but a food allergies, mainly from milk. And without testing, stop milk. A lot of people started doing, do the skin prick test or specific IG. If you're negative, do the patch test. The patch test also T-cell type of immunity also, we can able to get this type of patients in this type of patients. We started seeing rapidly, my 80% of my practice now at present, both pediatric, adult, only urticaria. I don't know why I get so many urticarias in my practice. We started getting plenty of urticaria without any reason. Investigation not found. Then we started in children, very especially in lady girls are coming, and we used to do thyroid profile first. Thyroid antibodies we do. Antibodies are highly positive. Then we do called as ASST. That's the word you wrote here. That is autologous serum skin test we used to do, which we used to do positive, whereas sodium chloride is negative. That is saline, and whereas your own serum will be positive, as good as like histamine. That is the one thing. And we started using the Omazulam for children above 6 years of age. And we get a very good results. I'm telling you, because we have to know this, because I'm going to talk about personalized treatment, personalized medicine in allergy. At that time, it will be very useful. A lot of patients come with that urticaria rash, exacerbations. I took this tablet, that's why I developed. I took this food, I developed. I took this, I had a fever. Lot of misconceptions are there. We gone to think and we analyzed most of the patients. We found out that it is not due to the fever or virus, or it is not due to the drug. It is due to the threshold of the urticaria is coming down. Everybody has got allergy threshold. I always tell to my students when I was there, a lot of my students are here also there, that any threshold, your threshold will be reduced by genetically by given God, or afterwards this genetic influence is there. Whenever there is you are exposed to the allergens, or maybe severe stress, what we found, and menstruation, what we found, and hormonal imbalance, what we see. Next case I'm going to talk to you. Infection, it reduces the threshold. NSAIDs reduce the threshold. Alcohol reduce the threshold. That's why you develop urticaria. Don't blame unnecessarily that thing, this thing and all, because it reduces the threshold. That's why you develop the urticaria. We taught them, we educate the public, and we told the patient that don't blame unnecessarily. You continue to take at that time, but if it is appears, definitely you have to use the treatment modalities properly, and we educate them. And this girl is the first case in Indian history, and a lot of other cases also first case only. This girl is come nearby Coimbatore, has come with this type of patches all over the body, and more than several years, 2 years duration, she is coming. And so on to that thing, using several steroid creams all the time. She is a known case of allergic rhinitis. Then we saw immediately, we did good history we took, and we found Nandivaram, Vardhanam pool valla vachindi. That's why I'm talking flowers is the main cause for this thing. And we did patch test, positive has come, and we told them don't go near to that, and child improved. Now she is not coming to us also. That is why very good improvement is there in that thing. I think it is very important thing. You have to find out the cause rather than giving steroids all the time. And she went into depression several times. By the parents are telling, parents are so depressed because anybody's skin is involved, naturally they will be very much upset. And coming to food allergy, what we found in food allergy when I was talking in the children, this is the first case of mine, what we saw in this patient come with severe diarrhea, vomiting. Diarrhea off and down will be there. Admitted several times in the hospital, and the thing, and came to our hospital with metabolic acidosis, severe sepsis. We thought we started with IV antibiotics, but child is, once IV fluids and antibiotic given, child is improved. But main thing is IV fluids only very, very important here. And when we give IV fluid, child improves. Again, within few hours, child will go into again same type of illness. Like hypo reaction will come, and child will be very, very difficult to think, and parents are very apprehensive already they spend it. And we found this thing is called as first case of PIPS in now, as per my knowledge, that thing previous afterwards now I got around 10 cases of PIPS, that is food protein enterocolitis, induced enterocolitis syndrome. This is due to cow's milk protein. What we found in that thing is not responding to between also. We did all the tests, we didn't found. In fact, we did such a small child, we did the endoscopy also. People helped us a lot. And at last we thought, why can't we try other milk? Then we started amino acid formula. Child is improved drastically, and naturally the patient is now at present in USA because father is an IT professional. And now they phone me often. They say that child has developed asthma on in corticosteroids. So vomiting and unresponse and repetitive emesis of same food whenever you take, and needs and intravenous fluids, must always think about this case in a very, very small child. By 1 year, most of them overload. This girl has given me good lesson again to me. This is also from Andhra. One of our friend pediatrician referred to me when he came to us. Severe anemia and Cushingoid facies and several irritability, and all parents are really upset because too much loose stools and mucus since 8 months of age. 13 months. Parents are really upset. We did a sigmoidoscopy already done outside, but they diagnosed ulcerative colitis. But we diagnosed it because I must be grateful to the Apollo pathologists. We have found out this thing is eosinophils, more than 50 eosinophils, and there is hypertrophy of the lymphoid tissue in the sigmoid colon. Then we took the biopsy shows eosinophil. This is nothing but a eosinophilic proctocolitis. And this is our case. Afterwards, plenty of cases of eosinophilic proctocolitis started coming, and we investigating now, and we are not delaying it, and we are teaching everywhere, all over the things. I have another case of one of the child who has come from Bangalore, also eosinophilic allergic eosinophilic enteropathy. Actually, that patient I didn't put because big history is there and very difficult to treat this type of patients. The child has come from AP, again Andhra Pradesh, has come to me, come to the hospital, admitted in ICU. Whenever in the ICU, it's become all right. When you shifted from the ICU, the child will go into severe wheeze, and we did all the tests, everything. People thought it is maybe only aspiration, but when serum specific IG, everything is specific IG. I send it for milk because mother is telling that whenever I feed milk, child is developing. Mother is not giving breast milk. That is the reason why. And cow's milk. This is the first case of us cow's milk presenting as a wheezing, especially India. This is very, very old thing, and now the child is almost 10-year-old child. This is the child. This girl is from abroad, actually Abu Dhabi. They came to us because the child went into several times anaphylaxis. Even the smell of the milk, child went into anaphylaxis. And she used to run away, and she was admitted several times, given so much of adrenaline and all. When they come us, it's very, very high, and we diagnose it as a food-induced anaphylaxis. Afterwards, we given sublingual immunotherapy. Child is doing very well. This case, again, another taught us new lesson to us. This 14-year-old female came to us from nearby 1 or 2 kilometers from Tiruvannamalai, where they came to us with, when admitted in a hospital with anaphylaxis, several history of anaphylaxis, urticarial rashes, and all these things. When I went to Germany few months back before going, there I met Dr. Beheller. I'm going to show his photo later. And Beheller had told me, this gluten increasing in the Europe, why can't you try in India whether, sir, we don't get gluten in South India. It's no, we won't. Let any of you take, I'm giving free of cost, which is very, very severe costly. Then I did just like that. I tried gluten, so much high, this child. When I took the history, and mother just that parota she likes very much. She eats the parota and go to school, and then the time of the school, she fell down and admitted. Then what we asked us, every time is not happening. Only certain times is happening. Then we gone to the history and asked us that whenever is going by cycling, she is falling down there, and she will become anaphylaxis. Then we thought it is a case of food-dependent exercise-induced anaphylaxis, and we sent to the Sweden when I was the investigator for the ISAC study. There is positive of omega-5 gliadin has come. Now we are doing here in India. At that time, not there. Omega-5 gliadin is the marker for the food-dependent exercise-induced anaphylaxis. This is the first case of us. Afterwards, we had 27 cases of food-dependent exercise-induced anaphylaxis. And now 27, now at the time of 15, we presented a paper in European Academy of Allergy and Immunology. My son has got a best paper award for this because it is the rarest rare case we picked up. Even Europe didn't have so many cases. They say that we have plenty of cases. We got a chana dal, we got a prawns, we got a milk, we have so many things. And only thing, any patient who comes with anaphylaxis, we are taking a good history nowadays, and we are picking up the cases. Now, how to manage this anaphylaxis? So many anaphylaxis coming, and this EpiPen, $500, $400, $300 in Dubai. Even asked them very, very costly to get. Then what we thought, community, we are getting a case of fire anaphylaxis, we have got honeybee anaphylaxis, we have got mastocytosis cases, all going for anaphylaxis off and on. Then what we did is that thing, we loaded adrenaline, given 0.15 ml for the children and adult 0.3 ml for adults, and put it in the covered in the plastic, the black cover, and put it in the spectacle box and give to the patient. This worked for 3 months. If anything happened, they feel like anaphylaxis, they know that symptoms very well, you can give it. One of the dentists who used to get the fire ant anaphylaxis, she want to use it, she was using very well. One day she taken out, she didn't get anything. My God, they admitted her because that what she exposed to the light and it becomes spoiled adrenaline and not worked well. So what I'm telling you, it is a light sensitive but not heat sensitive. It is heat resistant. We can use it for 3 months. 3 I used to give to the patient, and 1 in the pocket, another in the school while going, and 1 in the house. You can able to keep it. And this is another child who came given us another lesson to me. I learned a lot, but it was diagnosed abroad, but we are not knowing about. This case of this girl has came to us, investigated thoroughly all over the place. But she came for urticaria angioedema only. She came to us and she said that prawn, fish and chicken. But when you do skin prick test, I didn't find anything prawn or anything. But when I asked her, she said that she's a case of celiac disease. I asked her all reports normal. How it possible celiac disease? Then we did again by giving the gluten diet. We did all the tests, every test, including genetics, everything normal. Then what we thought, then went into literature and that non-celiac gluten. I picked up so many cases of non-celiac gluten afterwards. This girl is almost stopped the gluten, and for the thyroid antibodies are there. Autoimmune disease, she's taking on homozulan, doing extremely well now, and very good non-celiac gluten. This child was blamed as a celiac gluten. Psychological lot of problem is there, non-celiac gluten. What is non-celiac gluten? Non-celiac gluten is the one where it presents like a celiac gluten. Celiac disease only. But you investigate all parameters are normal, and then only you can go. Why it happens, not known. It may be an earlier feature of celiac, also not known, or it may be one of the phenotype of the gluten type. Gluten ataxia also there nowadays. I had a case of gluten ataxia also, but that is, it is more of a neurological one. We refer to them, and after doing the skin prick test, it is gluten induced. Common allergies in my center, we found milk only mainly, and afterwards egg. Now lentils are increasing. This is old data, lentils are increasing. And this guy has come to us with this very 11-year-old girl, almost highly depressed child, refused to go to school. She developed an ulcer in the upper lip every time. We thought it's fixed drug eruption, but not. Investigate. I was referred to a pediatrician to me to see it, and I am not able to find out really, and ask them. I am not able to find. I told they are very pressurizing me. You are not able to find out. You are not able to find out. We did skin prick test negative. We did all the tests negative. We did patch test negative. Everything negative. And the patient has gone back and told to the pediatrician. Pediatrician told that he is the man who can able to diagnose you. You cannot go anywhere. Then they come back again, and then again good history. They are telling that when we take meals in the water only it happens. And after good history, we zero down to sambar. When zero down to sambar, we did yellow dal, no reaction. We did send for serum specific yellow dal, no reaction. Lentils normal. Then ingredients, we checked it, curcumin and turmeric positive has come. Then we did patch test with the same area, and here it comes very well. This is a food fixed drug eruption. First case we have seen in our history, and second case I recently seen with the same yellow color agent only. I think people must be aware of the nowadays. We are seeing a lot of coloring agent. Children are very, very fond of these type of things also. We can get in that thing. So how many colors are there in this thing? Yellow, red, carmine, all this red color and all these things. Children are fond of this thing. Please understand this thing. If you are not able to find out the cause, better to investigate that thing. Coming to drug allergies, what is our experience in the drug allergies? And this is the case from Andaman. He has come to us to know that whether it's not or not. He was given a amoxicillin. I thought I was wrong actually. It is NSAID, not amoxicillin. When I given amoxicillin, we did skin prick test, we did intradermal test. He was only urticaria angioedema. He was very scared of giving amoxicillin or any penicillin, anything at all. And we did challenge test. We were able to find. We did it with not amoxicillin. What we did is that we used major determinants. That is called benzyl polylysine, L-lysine. We cannot use directly what India, what you take out the amoxicillin and dilute it and give. That's not the correct. We cannot get it. Why? What is the reason? I'm going to tell you later. Penicillin is surrogate marker for this thing only. Penicillin or cephalosporins or this this beta lactamase, all these things is we have to do only major determinant, minor determinants. And why you have to do allergic determinants? Amoxicillin is a penicillin group. It has beta lactamases as heptanes. It binds it and releases that thing, that beta lactamate ring. Once it releases the beta lactamase, then forms the benzyl penicillin. This is a cause for that. If you do this thing, we are not able to find out. When you do this benzyl penicillin, the major determinant, then only you find. If it is negative, then you can say that patient didn't have allergy to that thing. That's why in abroad, penicillin, nowadays patients come, don't give me, doctor, I am allergic to Ceftriaxone, I am allergic to penicillin, I am allergic to amoxicillin, I am allergic to cephalosporin, I don't give me this thing, that thing, that thing. So many drugs they say. Just namesake only. And we are afraid to give it. In abroad, there is one of the wonderful study done in USA. They called all the patients with penicillin allergy and investigated. 99% of the people didn't have any penicillin allergy at all, or they overgrown the penicillin allergy. That is the one thing what I want to tell you is that don't blame the patients directly and throughout the life will be, and also at the same time, you must do properly also. This child, paracetamol, we are doing a lot of work on paracetamol allergies. We are doing paracetamol, more of a non-hygiene mediated allergy. And this patient has come to us from Kalpakkam, actually nearby center, and came with fever. When she takes fever, they get paracetamol. When you take ibuprofen, you will get, and any alternate drug, all the patients are mefenamic acid, everything she is getting. Parents ask me what drug I can take for the fever. Whenever I get high fever, what to do? That is the only thing they ask. COX-2 inhibitor, COX-3 inhibitor, this is weak one, and detailed clinical history, graded oral paracetamol challenge we used to do. This child is able to tolerate only 25 milligram, only able to tolerate. That is the reason why we can tell them that only 25 you can able to use it, not more than that thing. And there are two types of paracetamol. One is cross intolerant reaction. If you are cross means other drugs also we cannot use. Selective reactor. We are only allergic to only paracetamol. Other drugs we can able to use it. That's why we have to find out while doing, we have to not only do the paracetamol, you have to do mefenamic acid, you have to do the what you call as ibuprofen, diclofenac, all these things you have to do before going to our COX-1, COX-2 also you have to do, itracoxib, all these things we used to do. We did a study, we found out that thing, most of them are oral challenges. We did 8 only because out of 11, 3 people didn't agreed, and they found out by oral challenge 8 only we can able to find out. That's why I'm telling you, IG mediated is very, very less compared to that thing. And this girl has came to arterial rashes and rhinorrhea, 14-year-old girl. I have another 9-year-old girl also same comes like this arterial rash off and on, 1 or 2 episodes a month. And she says that 7 to 10 days after taking beautiful, extensive history only. I'm telling you, it's not very easy. It looks very easy for you. But taking extensive history, 3-4 sittings, then we conclude that every time she is coming, every month, same time. Why she is coming same time? Then especially 7 to 10 days before menses. Then we go on to the literature and show that progesterone, hypersensitive reactions are increasing. And we got around 5 cases of progesterone. Now, especially adults, we are seeing a lot of progesterone mainly because of this in vitro fertilizations are increasing and progesterone hypersensitivity react. A rare disorder, and especially urticaria angioedema, asthma increases, anaphylaxis will come, and vulvovaginitis, macular papal rash, all will come. Mainly because maybe exogenous or endogenous sources also. Especially luteal place will happen in this type of thing. Detailed history with intradermal testing can able to help us. This case we presented recently in our European Academy of Allergy and Clinical Immunology of 5 cases of 5 patients who diagnosed progesterone hypersensitivity. This is one of the very good thing for us. Why our patient urticaria increasing, especially whenever a patient lady comes to me in the childbearing age, I will ask that when is your menstruation? When is due? Or your irregular cycles or not? It is given as taught as a lesson. I think this is the only specialty in India. Medicine is a specialty in India. I can tell you, patient teaches you and pay you also. Your pocket is full, and also you learn, your brain also full. And we have developed a lot of foreign interactions with the people. And he is a Behaler, my dearest friend is there. And of course, I didn't put Nicholas. He is also my dearest friend. I didn't have a picture was there, but I missed it. And this is Dharmo Fisher, medical director with us, and American Academy of Allergy, Clinical Immunology president. And this man has done food safety work. This man has done food safety work a lot. He is from actually Netherlands, he has done Holland. He has done a lot of work on the component resolved diagnosis and all. So much work done. This lady has done a lot of work on allergies. We have got a good interaction with them. We are learning a lot from them and giving to our patient. And here we are doing a lot of services also, and we are doing the patients camps we are arranging. We are doing allergic skin prick test. Not only this thing, we go to a lot of ENT, pulmonology. This is US Rao. I think all of you know him in Hyderabad. I gave a talk in their hospital also, and I gave a talk in Armed Forces. I was given this Vaijaratna for my entire service in Nellore district for doing the service to that, and they given me. And we have gone to the media, we have published our own thing, and I've gone to so many papers are there, we didn't know, and educate the public, all these things. During pandemic also, we are sending WhatsApp messages to all the people to educate that thing. Immunotherapy service, that is one of our strength of this thing. Immunotherapy is the one what we used to do for permanent therapy for the allergic diseases. I think that is the only one which can able to natural history can be broken, or history of the allergic disease can be halted, or it modifies. That is one thing what is happening, where we will give small quantities of increasing quantity of that allergen given to that, what you are allergic to that, so that patient develops his own tolerance. So you are not have allergy. That it is a God has given tolerance. Whereas we are giving by immunotherapy, developing tolerance. There are a lot of methods are there, subcutaneous immunotherapy, sublingual immunotherapy, oral immunotherapy already using all over the world. These two are very famous. This is more than 100 years old. This is about 30 years old. And these two are still infant stage, not even infant, not born at all. This FDA is not approved. This is not at all going on. This is oral immunotherapy. Now only just started along. We are also doing a lot of work in India for oral immunotherapy. This case, very small child. Everyone afraid that giving injection to the small child is possible. That's only is to say immunotherapy every week used to come and take the injection for 8 weeks. Afterwards, monthly once we used to give. This child has got severe night cough and severe perennial allergic rhinitis, asthma. Now he is doing very well. That is allergic rhinitis, asthma progression. We stopped it. Previously, a lot of people mix the immunotherapy, like doing what is that thing, house dust mixed with pollen and all these things, mixed with cockroach, all these things they do. But nowadays, everyone believes that monoimmunotherapy is more important for polysensitized patients. We believe, this is my slide. Actually, a lot of people hide my slide. Most of the allergists have taken my slide and they are using. What we say that thing is, everyone has got allergy threshold. You are exposing to so many allergens, but still you don't develop any disease, including all these things. Mold means aspergillus here is there, of course. And dust mite is there, aspergillus is there. And on the top of that, you are exposing to cigarette smoke. And you are getting viral infections. Why viral infections only causing? You are not causing viral infection. You are allergic to that and exposed to the viral, exacerbate the disease. That is the thing what happens in the winter season. And suddenly exposed to some pollen. And you develop symptoms. You blame the pollen only, but not actually this is a response for your disease or any of these things. Then we proposed, and not only we, actually European Academy is proposed this thing, and we started using that thing, monoimmunotherapy, only one allergen, even though you are allergic to several allergens, we do that thing. And we suggested using the dust mite, which is very good reaction, or which got a very good response to the immunotherapy. Or if any pollen is there, you can do pollens. India pollens are very less compared to dust mite. This case come to us. I think you can listen 1 minute. This girl, what is she telling? No, I think she's not able to.
Hello, sir. I'm Jaitrika. I want to tell my experience before and after my immunotherapy. Before immunotherapy, I have disturbed sleep because midnight, most of the night, I'll get.
I think I stop it because the reason is that it takes long time. And this girl has come to us. She's so shy, so afraid, depressed. Is any cure is there for me for my atopic dermatitis? She asked us. And she was already using cyclosporin and tacrolimus and moisturizer and steroids left and right creams are using. She's moderate severe persistent asthma also. We started immunotherapy for dust mite. Child has become so nice. Now she's a good badminton player. She's playing very well. Her own story takes about 2 minutes. That's why when she came, dust mite levels are very, very high. And now she's doing very well. And we stopped immunotherapy. It is not coming. And this girl is from first case of mine who have got come to, sorry, I have to make. Yeah, I think this is the first case of us has come from Siliguri, actually in Apollo Hospital. First case of mine who started sublingual immunotherapy for milk. She has got several attacks of anaphylaxis, difficulty in breathing. Parents are really worried about that. And the milk is so more very, very high. At that time, I don't have components. I have not done the component immunotherapy. We started immunotherapy. This child, now the child's from 100 to, it has come down to 11.5. Sublingual immunotherapy worked very well. This child, continuous follow-up. I think they have taken appointment for this month, end of the month. I think by the time it has come down to at least 2 or 2.5, I'm going to stop the immunotherapy. And we presented a paper about our 26 patients of sublingual immunotherapy in cow's milk protein allergy. Wonderful results we getting. And European Academy of Allergy and Clinical Immunology. We got a very good response from the people there inquired about our thing. This is one of the game changer for us. I think this is the first case of us. We did SOTI, that is specific oral tolerance induction. Oral immunotherapy, we did it. This is a case of anaphylaxis, urticaria angioedema. This mother is telling you small story.
Good morning. I'm Allergy. My daughter's name is Kesha. She's suffering from milk allergy since birth. She did not face any symptoms till 6 months. Till she was 6 months old, she was okay. Till I breastfeeded her. In 6 months, I started feeding her with idli and milk. Her lips started swelling. She started developing symptoms. Her eyes turned red and she started fainting. We rushed to the hospital. Our pediatrician found out that she was allergic to milk. He immediately asked us to stop all the dairy products and wait until she outgrows her milk allergy. But after she reached 3 years old, 3 years also, she did not overcome her allergy. Her symptoms started becoming even more worse because she used to go to play school. She started eating things and stuff, dairy just there without my knowledge. She used to develop hives, rashes, swelling all over her body. It would arise at any time of the day. I struggled a lot. I did not know what to do. We rushed to our pediatrician again when she was 3.5 years old. He sent us immediately to Nagaraju sir. Developed symptoms when I used to feed her with milk, or when she opens a fridge where there is a milk package in it. Even when I eat curd, I wash my hands and touch her. Immediately she will develop rashes all over her body. If any kids kisses her or not.
I think now you see this.
Good morning. I'm Yar.
Okay, I think we don't want to go with that thing. I think this girl is taking 400 ml now. And you know that thing, SOTI has helped a lot. This lady I gave only 1.5 years only. First I started with sublingual immunotherapy, once tolerate little amount of milk, and that milk onwards I started with the milk antigen, which is imported from USA. They are also doing studies. I also one of the person included in the studies, and we started that thing. First case of mine. Afterwards, we did five cases, and all 5 we present in European Academy of Allergy and Clinical Immunology. I think nobody is doing this SOTI at present. Only in certain parts of the world, they are doing few centers only, especially Europe, some centers, and USA, there are some centers. And we are the one of the thing. And there is a labor man as a man who told immunotherapy he is going to give to the mothers, if you give to the ladies, and their offspring, through that we can able to protect it. This man has produced this thing before immunotherapy, after immunotherapy, before a pregnancy given, and then how the children have not suffered so many things. Then we realized that what happened, our patients are not coming regularly. And what we have started in the, my wife is a gynecologist, we started all ladies who have come to us with immunotherapy. Suddenly we realized first child has got asthma, second day they didn't have any disease at all. Eczema is coming down, allergic rhinitis. But we found in our results, we didn't find wheezing. Though Lieberman told that it is wheezing. We have done for 50 cases. Lieberman told that all allergy disease reduced, but we didn't find wheezing. Maybe we have to follow for quite some time. Maybe, I don't know, maybe early stage of the disease. We followed up for only 5 years. Immunotherapy to the respiratory allergies, all respiratory infections. This is the one thing what we found here. There is one of the study done by they published in American Academy of Allergy. We thought after starting immunotherapy, suddenly our OP is falling down day by day. What is happening this? Then we realized that all adenotonsil infections, sinusitis, chronic otitis media, recurrent viral infections has come down. And we went to the literature. We found that this paper is published there, and 30% of the people are reduced. And we found this is the one thing. 18-year-old boy was admitted in Apollo with anaphylaxis, and we 3-4 times, and last time we can make out it is due to red ant anaphylaxis. Then we had the first case, and this is the only case I did up to now, is red ant anaphylaxis immunotherapy. And PNM immunotherapy, generalized cutaneous lesions we have to do, systemic reactions we have to do. Otherwise, normally reactions we don't want, and localized reactions we won't do. And that's why, of course, we are started doing for the, even for honeybee and yellow jacket and all doing, but this is the first fire ant immunotherapy we have done. We prepare our own immunotherapy, we teach to the children, and we educate to the people also how to do immunotherapy. And we did a wonderful study between we are going to publish shortly, submitted for publication. That is that in children, standardized versus non-standard. When I was in the before, standardized 348 and 190 when standardized one used, how it is improved. It is so drastic improvement is there, we can make out. And like that in adults also is very, very useful for the people. Standardized preparations are very helpful. And also we found out that slit is very effective in children compared to the adults. We have found out that thing. And the problem with slit is that children may not continue with the slit. That is discontinuation biased in pediatric age group compared to adults. And use of medications and improvement of symptoms, all these things reduced in children faster compared to the adults. And same thing, and complications wise, this is very less complications what we found in adults compared to pediatric. Pediatric has more, slightly local complications are more. And we thought this is the time for us to go for personalized medicine. Old concept, that is the one thing. Different patients respond differently to medical intervention. Oh, dawa de diya, I am not effective, not to me, like that people are. Now, new concept is that all patients are not equal. Same medicine may not respond. And there must be phenotypic different, endotypic different, genotypic different, and you must have a targeted therapy. Is it possible in India? Yes, it is possible. We are doing. And now you have to identify which type of people at risk. Evaluate visual property. We see like this, what is the possibility, and then we treat it. I think one size fits for all. All ready-made for your ready-made clothes, you can fit it, but not precision medicine, more of a tailor-made. So unbiased will be there, early intervention will be there, and results are excellent. Results will get targeting. I will tell you what is that thing. This is the way we do nowadays. What is the clinical phenotype? We identify as a patient comes. I see the patient. What is the age? How it behaving? Is got allergic blocker, or is a blocker, or is a I think Pawan, somebody is, I am not able to read the thing. Somebody is doing like this. Clinical phenotype, whether it is allergic rhinitis blocker or a sneezer, we can able to find out what type is there, what age is there, whether he has got a lower involvement or not. Clinical phenotype you can make it. Then we start treatment accordingly. If he's not responded, then you do molecular phenotype. I got molecular phenotype, I can do it, but you don't have. But disease endotype, that is whether it's neutrophilic or eosinophilic, you can have, or mixed by doing a FIAGO. You can able to do it. It's not a problem. Eosinophils, you can able to find out and we can able to treat it. What is therapeutic? New type, latestly included. What is that? You saw in phenotype, and you think that this patient may be improved with homozolam. Urticaria. I saw the child of 14 girl with severe urticaria already gone to the doctor for 6 months. Everywhere they can come to me. I know that the child will respond to homozolam. Straight away I start with homozolam. A patient come to me with that already using inhaled corticosteroid properly, not responding. That is steroid resistant. I know. I have to go for other thing. I can go for biologicals. That is called therapeutic. Treatable type of the phenotype is called therapeutic. Now another one, regiotype. This is can be done in India. It is not a problem at all. And regiotype. What is regiotype? See, in your region, certain allergic disease is common. What are the exaggerated patterns? I will tell you example. In India, most of the thing is dust mite. Atopic dermatitis mainly Th2 and Th17. Whereas in abroad, Europe and USA, they are more of a Th2 type. So treatment is differs, here differs. And also in if you get a polyps, nasal polyps, in USA, most of them are nasal polyps due to eosinophilic. In India, nasal polyps, most of them are neutrophilic type. So we have to know about younger the child, more of a neutrophilic type of asthma. What if people, a lot of work done. We are not doing any bronchoscopies, that's why, and bronchial biopsies, we don't know. According to regional types, and inquire about his symptoms and what is the regional happening, what is the pollen, dust mite, whatever may, according to that is called as regiotype, recently included. I think it is possible India to do it, and this way we are treating it, and my patients are responding very well. Prevention of allergies, primary prevention, breast milk, best for everyone knows, and environment, unnecessary environmental exposure. If a patient, what if you go to a doctor, what you will say? I don't want to blame that thing. They say that don't go to the dog, don't eat this food, don't go near to that, don't go to the park, don't go in. What is the life of the child? I will tell you, need not avoid any unnecessary unless you find it. And do the physical exercise. Endorphins will be released. You feel better. Endorphins are very, very important anti-inflammatory thing also. Traditional diet, go for traditional. Western diet is killing us. Go for a traditional diet. Do that thing. I don't have time to talk about all these things. And don't use unnecessarily antibiotics. Increasing your Th2 type, Th1 to convert it to H2 type. Take fermented food, always better. Use curds. Our olden days, we used to use a lot of curds. Now, all children run away from curds. That is one thing, of course. Passive smoking for children, adults, active smoking. That's fine. What is secondary prevention? Almost same as like this, but you start allergen immunotherapy as early as possible. That is the one thing, so that progression will be stopped. Hit it hard. Hit it very early with anti-inflammatory medications, so that maintain long term. What you do in atopic dermatitis, I just give you an example of atopic dermatitis. What patient will ask them to give, and proactive therapy. Use it for weekly once or twice. Like the patient won't. I'm all right. Why I have to use? Inhaler, you will tell them, I'm 10 days. I'm all right. Why I have to use? Why you ask me to use long-term treatment? That's why they're getting again and again. It is not only a mistake of the patients, also must act. Educate the public. and do that thing. Then they will definitely help us. And this is now everybody talks about probiotics and allergy, microbiome allergy. The day will come, we are going to talk about only another 5 to not very far off. 5 to you are going to decide it. I am a renal transplant. All of you know that thing. I am taking tacrolimus. Why my tacrolimus increasing, decreasing off and on? Very, very rapid fluctuations are going. What is the reason? I went to literature. I found there is one probiotic there in the bacilli, which is sitting in the microbiome, sitting in the rectum, is a cause for that. It is less, my tacrol levels will go down. It is much better, the tacrol levels will be normal. That is the thing happening. Now, it is very important, despite this, how it is increasing neuropsychiatric manifestations. I am telling you, most if you don't treat it properly, a lot of people will get back to depression, anxiety, all will develop later stage because of epigenetic modulation will occur in this thing. I suggest endorse health, not allergy. Don't look into the allergy. Healthy is very important. Go for run. Don't ask. One of the patients has come to me. I want to dance. My mother is father not allowing me. You dance it. I will give you medicines. I told parents, no, how can she dance? Yes, she is a famous dancer now. I don't want to tell her name. Very, very famous in South India. So what I am telling you is that endorse health, strengthen the tolerance, adopt a new attitude allergy, avoid allergens. Mandatory one. Whatever unnecessary, don't stop the thing. I am allergic, several things, 40 things, don't stop it. Recognize and treat. What is the recognizable, which is exaggerating you? What is the cause? You do it. Improve air quality. Most of the people in India living in closed houses. When summer, they close all the rooms. When winter, they close the doors. When they will open, where is the fresh air? And you using this ACs, which is not wall ACs and all. Wall ACs will at least take away outside air into inside. And this window ACs will take out. Wall ACs won't take out. Windows ACs is better for that because the noise we are changing. So we are changing our system. That's why allergy is increasing. Allergy health, I call it as allergy health. This is a very, very important thing you have to learn about this. What is the mission for me? Be allergy free. It is not possible. Then what to do? Give a quality of life to the allergy and asthma patients. That is very important. We can give the life to them. Quality of life. That is the thing what they expect from us. All allergy patients, food allergies, really, some urticaria, they are itching. They are really crying. Everybody, unless you put it into soup, then only you realize what patients are feeling. Asthma is better to treat, easy to treat, rather than allergic rhinitis, food allergies, and urticaria rashes. So what is the thing is that thing we have to give a quality life to the patients. That's why we started a fellowship program in allergy and clinical immunology, first in the country by a medical college and medical university. And we started certificate courses in immunotherapy and also certificate course in allergy immunology. Those who are not able to come work for the FSCI. And even online course also we started. We started a lot of chapters writing to the books and a lot of books we wrote by us. First edition, second edition. This book is a Bible for most of the pediatricians. They're doing it. And I think this is the points to ponder. I don't want to take as a summary. Then I think that allergy disease increasing in prevalence, not only increasing prevalence and severity also increasing. Allergy rhinitis is very common in children and misdiagnosed with a common cold. Cow's milk protein allergy present both in IgE and non-IgE. Shifting of the pattern of the allergic disease seen recently. What we see cow's milk allergy over 2 years, not happening, 10 years also, 12 years also. Changing a pattern of the allergic diseases, changing the climate, changing the allergic diseases, changing the pollen seasons, changing the pollen severity. Atopic dust mite severity is increasing indoor activity. Changing pattern. We have to learn every day. Learn, relearn, unlearn is very, very important for us. Prompt identification, treat early stage. This is treated early. Don't prolong it. You know it is allergy, but still you are giving medicine. Just do it properly. Second generation has given a better choice. Don't use first generation. Molecular diagnosis, wherever applicable, do it. Personalized therapy is gaining a momentum. Do it. And adrenaline is a choice. And we can give 1 rupee adrenaline. Do it free of cost for all the patients. Awareness and identification. Drug allergies are very, very important. And food allergies are very important. And immunotherapy is the feature for the allergic diseases. Thank you for this opportunity given to me. Give a talk on very famous person, Dr. Reddy sir, and I am very grateful to the people who have given me this talk. I just finished within 1 hour rapidly, I think, maybe. Thank you, Dr. Surendranath. Take over, please.
Thank you, sir. Thank you. Your journey is amazing in the field of allergy. I hope you will aim for higher heights in future
1 minute.
and bring laurels to the India. Now I request Madam to felicitate sir. Sir, Madam is there.
Yeah, she's.
So kindly request her to felicitate you.
Namaste.
I think I can see only.
Yeah, it's visible, ma'am. So thank you, Nagaraj sir. We are proudly say that we are your fellowship students. Myself and Dr. Surendranath sir were both classmates in fellowship in allergy and clinical immunology. I think I request all to honor sir.
Thank you, sir.
So that is
Thank
the
you very much, sir.
the honor of the oration and also the memento, a beautiful memento.
I think
Ma'am and sir both are really a loving couple. I can say that, sir never used to, defame any wife. I think he used anybody plays jokes on wife, he used to condemn seriously. So they should be adored, adorable. Like that he used to say us. We take your suggestions very seriously, sir. Now, sir.
thank you, Pawan. Thank you very much.
So, sir, madam is really a better half of sir. We all know that as a students. How she used to take care of
I
us.
want to tell you one word here that without her help, I am not able to become a.
It's indeed a proud moment for
Specialist.
all the students, sir, to see ma'am and you both in one frame. And madam, felicitating you on behalf of Pediatric Academy of Telangana State. We are really honored, sir. Thank you for accepting the oration.
Thank you so much, sir.
Pawan, can we close it?
Yeah, sir, 1 minute, sir. There is a quiz, as we said, for the practitioners. If they're all ready.
You made it full by yourself. You can make it into yours.
Yes, sir. 1 second. I'll just share it. 1 second. So for all the people who are waiting still, I think there are around 80 people who have still waiting in the participant list. And so we'll have the quiz. So Pediatric Academy of Telangana State started this Best Delegate Award of the month. So 5 questions will be asked and 5 answers. The fastest fingers first. All the questions are from Sir's talk only. So whoever has keenly listened to Sir, I think they are the best attentive listener award will goes to them of the month. Every month we are planning to conduct this. And from next month onwards, we see that the gifts will be delivered to your home. We're planning some gifts also and certificate also. So with that, we'll start the first question. Whoever answers the first question in the chat box, first answer comes in the chat box, correct answer will be awarded, and we'll take their name and they have to type their phone number also to contact later to reach out to you. Okay. So with this, with the blessings of Dr. Nagaraju sir, I'll ask the first question. And there is a Best Delegate Award 2021 during our state conference. And for those people who have get maximum credits, like each month, those who are repeatedly getting every month, those people, the highest scorer will get the Best Delegate Award 2021 during the conference. So with that, let us start the first question. So please type in the chat box. I request Dr. Sri Krishna RSV and Veeresham Kamtala from Nizamabad to help me in this regard to see who is whose answer is first. Yeah. So what is the commonest cause of food-dependent exercise-induced anaphylaxis in India? So 30 seconds will be given.
Gorika Bansal is answered first.
First
Sir,
answer
you are
has
seen,
come.
sir?
Gorika
Yeah.
Sir?
Bansal is answered.
Sir, answer has come.
So which one? Who is the first one, sir?
Gorika
can see.
Bansal. Gorika Bansal.
Gorika Bansal. So any other person from PATS?
Let me see.
From Pediatric Academy of Telangana State members?
No, all my students only. Nobody.
Okay. Sir.
Puteja.
So see, sir, if there is an answer who has I think then because we can reach out for present, gifts can be reached out only to people who are in PATS. That's the reason. Certificate can be given to all.
Srinivas Jekka.
Srinivas Jekka. Okay.
Okay, second question, Pawan.
The first winner of first question. So all will get the first certificates will be given to all the 5 winners. So coming to the next question. So how much percentage of patients with asthmatic children have allergic rhinitis? This is a little bit tricky question. Just read the question again and answer.
I think correctly answered.
Dr. Kuteja.
Same people from outside.
Sir, anybody from PATS?
Kuteja, one person who is from PATS.
Kuteja is not from PATS, but still you can see, you can find out anybody from.
All our students only.
Yeah, they're brilliant students. I know. So.
I think
Yeah.
Venkateswar Rao. Why Venkateswar Rao?
Vavi Rao, sir. Yes. Yeah. Yeah.
80%.
So anybody apart from Y Venkateshwar Rao, sir?
Murlidhar? No, he's
Who is
not.
a PATS member who answered correctly? You can just unmute and tell us.
B. Madhusudan Rao. Who is B. Madhusudan Rao?
Dr. Lakshman Kumar.
Sir, Lakshman Kumar, sir, మీరు Y Venkateshwar Rao sir కన్నా ముందు ఆన్సర్ చేశారా దాన్ని?
ఇద్దరికి ఇచ్చేయండి.
B. Subramanyam. B. Subramanyam.
Now let us move to third question.
Thanks
Yeah,
to
Dr.
you. Very
Kuteja
well.
and Dr. YB Rao.
Nara,
And
Nara.
third question.
Third question.
Yeah, 1 second, sir.
Okay, next time.
Yeah, expand SOTI. It is there in the sir slides. It's clearly mentioned, sir, clearly mentioned about that. SOTI.
SOTA.
I think again, Srinivas.
Oral tolerance indication. Oral tolerance index.
Srinivas Suteja. I think 3
Copy
people.
So, yeah.
Pawan, answers are seen in the chat box. No point. I mean, whoever puts the first answer, you put it because
Right,
answers
right.
are seen.
Right, sir. I got it, sir. Who is the first one, sir?
Srinivas Jekka.
Is the first one to answer? Good.
Yeah.
Yeah, now I'll move to fourth question. What is the name of FDA approved oral capsule for peanut oral immunotherapy? This is also mentioned on the last line of one slide. It is very clearly mentioned FDA approved oral capsule for peanut oral immunotherapy.
Srinivas Jekka.
Again, Srinivas Jekka and Kuteja, P. Srinivas, only that two. And
So only first one will get. Fastest fingers first.
Srinivas Jekka.
Yeah. Now the last one, last question. One second.
I think Kuteja sir.
Yeah. What is the best way to diagnose beta-lactam allergy? What is the best way to diagnose beta-lactam allergy?
I think PPL, he wrote, full name you have to write. I think somebody has written, Venkateswar Rao Elluri is the first person to write, major determinant.
Sir, YB Rao, sir?
YB Rao.
Okay.
I think before that somebody wrote PPL, but that is Kuteja, but I don't, I want major determinant correct answer.
Right, sir. So Dr. Y Venkateshwar Rao. Yeah. Great.
Okay.
Yes, sir. Thank you, sir. 5 questions, 5 answers we got. Now, yeah, over to you, President, sir.
Thank you very much, Pawan, and thank you to the Dr. Nagaraju sir and Reddy sir's daughter and son who are with us. I request now Treasurer of PATS, Srinivas Rao, to propose vote of thanks. Dr. Srinivas Rao.
Good evening, sir. On behalf of PATS, good evening, sir. On behalf of PATS, I thank Dr. Major Dr. K. Nagaraju sir, pediatric allergist and immunologist, for giving an excellent perspective and good academic feast of the allergies and their management. And thanks, sir, for delivering this lecture of Reddy Oration. I thank the Central Vice President, Dr. Ravi Kumar sir, Central EP members. President and Secretary of PATS, and also all the participants of today's webinar. I thank each one and all, sir. Thank you very much.
Thank you
Thank
so
you,
much.
sir. We'll take leave.
Yeah.
Thank you, sir.
Now you can leave the session.
Thank you
so
for
Thank you, sir.
Eka Reddy and Achyuta Reddy also. Thank you. Thank you.
Yes, ma'am.
Yes, sir. And Achyuta Reddy, sir, also
Thank you,
thank
sir.
you, sir.
And everybody, Lakshman Kumar and all the people. who
Thank
are-
you, Andy. Thank
Thank
you
you,
for
sir.
having us. Thank you very much. Congratulations again.
I'm leaving.
Thank